60 years ago, President Lyndon Baines Johnson signed into law Medicaid, of course, providing a safety net for individuals looking for health care in this country. Republicans want to endanger that. We're seeing these actions take place right now with Trump's signature of that gross bill that he signed on July 4th. Now, what's crazy about this, Republicans keep lying. They lie to themselves and they lie to their voters. They consistently say, oh no, this is not a problem. We're not sitting here. Cutting Medicaid. And in fact, that's exactly what they're doing. It's happening over and over and over again. Now, what's even crazier is that Republicans in these red states, they're the ones who, with the voters who have the most serious problems. Like, I love these folks in Kentucky who have been saying repeatedly, oh, don't you touch my Affordable Care Act, but get rid of that Obamacare. Oh, we need to go ahead and cut these things. We need to cut health care, but then they're the ones who need it the most. It doesn't make any sense. It literally makes no sense whatsoever. So what you're seeing are Republicans who are consistently and repeatedly voting against their own interest. They're killing their own people. That's what they're doing. We talk about Medicaid. We're talking about people who literally depend on this to save their lives. We talk about North Carolina. When they resisted Medicaid expansion, you know what happened? Rural hospitals shut down. Folks had to travel 50, 60 miles to get care. Folks who actually died. These things are actually real. So let's unpack this and let's talk about it. Chiquita Brooks LaShore, the former administrator of the Centers for Medicare and Medicaid Services, joins us right now. And we're also going to be joined by Roger Mitchell, Jr., president of the National Medical Association. Chiquita, I want to start with you first. I mean, it is, when this conversation is had, it's a process conversation. It's a Washington, D.C. process conversation where what I keep saying is like, no, this is a healthcare conversation. And you have to put a face on it. And it's stunning to me to see individuals who literally are voting against the interests of their own constituents.
It's been incredibly painful, and I'm really glad that you started with saying people are talking about this as though it's a process. I have spent the last couple of months talking to people across the country about what this is going to mean to them. People have been in tears. People have called in and said, my kid is covered by Medicaid. My kid has XYZ conditions. I have multiple sclerosis. I have a disability and I'm going to lose access to my bipolar medications. I am a doctor who takes care of patients. What is this going to mean for my clinic? What is this going to mean to my hospital? This is millions of people's lives and livelihoods that are at stake with this bill, and it is really, I would call it immoral, just what this bill is going to mean to our country.
Well, when you listen to people who claim to be pro-life, but they support this bill, that's a bunch of crap. When we talk about the most, what are the most affected states? We're talking about 17 million people. What are the top 5 or so states most impacted?
You know, I would say all of them are, and in different ways. You are right to say that in many of the red states, this is going to be devastating. And I will just take a moment to back up a little bit about what was going on before this bill passed. We had healthcare problems in our country before this legislation passed, particularly in rural areas. And COVID really hurt a lot of hospitals across this country. I spent a lot of time talking to people, and Medicaid and Medicare prop up most of the rural hospitals in this country. And so you mentioned how North Carolina, before it had expansion, had hospital issues. So did Georgia. So does Mississippi and Alabama. And that's before this bill passed. So let's see, what does this bill do? It hurts red states who disproportionately have Medicaid people. But to the blue states, this bill targeted them. And so there are a whole bunch of provisions that don't say New York and California in them, but the provisions themselves are going to cut the ability of those states to cover the people that they are legally allowed to cover if they choose to with their own dollars. It is hampering those states that did take the expansion and phasing their dollars down and hampering their ability to raise revenues to pay for Medicaid. So that's what I would say. Yes, a lot of the red states are hurt, but the blue states are too.
Dr. Mitchell, I want to go to you because there is a direct impact on doctors, nurses. I remember when the entire Louisiana healthcare system, they were imploring Speaker Mike Johnson, do not do this. You're going to put our system in jeopardy. He totally ignored them. And so explain to folk what will be the impact directly on doctors when it comes to these Medicaid cuts.
Well, we know that, and good evening, and it's good to be here with you, and it's good to see Chiquita, who is really our Medicaid, administrator. We say that every time we see her. Physicians get paid. We receive dollars through insurance, and one of the biggest insurance providers, particularly for physicians that have made a decision to do the work in communities that are disenfranchised or disinherited, rural communities, urban communities, communities in the poor, those that treat disabled patients, those physicians that treat our pediatricians, those that are geriatricians and treat our oldest of our individuals, those physicians are going to be greatly impacted because now you're talking about treating patients that don't have access to the insurance to pay for their care. So that is one set of physicians. But then there's a whole group of physicians that are in hospitals, that are hospitalists, that are intensivists, that are emergency room physicians. We know that these types of cuts, these types of changes are going to lead to congestion within our emergency departments. It has to, and we're going to guard against it, but it has the potential to impact quality of care because long wait times impacts quality of care, and then congested emergency departments impact quality of care. And so the way that you deal with and ensure that healthcare costs come down is have more healthier people, not cutting access to people, because individuals will now seek care, but they'll seek care when they no longer can stand the fact that they're suffering from that disease or injury. So that means that care is going to be more severe. That disease or injury is going to be more severe, and they're going to come to care much later. And so it's going to be more expensive to deliver that care. And now the government is saying, well, that subsidy is no longer going to be available for the people that most need it. So the physicians are at the front lines of having to provide this care at no cost and at low cost, and so it's going to be a problem for our physician groups.
But again, it's not just people are sick. This is going to cause folks to die. I mean, this is it's a fact. We've already seen this. When rural hospitals shut down, it was people who experienced medical emergencies who had to travel further. I mean, every single minute was precious and people died.
Absolutely. I mean, and there are parts of this country right now where people have to travel for an hour or two to get to a doctor, and weather can make all the difference. I drove in Colorado a couple of years ago when I was CMS administrator. They told me on my way to a hospital, they told me that road's out 1 every 3 days of the year. So you think about what happens when one of these hospitals shuts down. This is maternal health in our country. How quickly can you get to a OBGYN to deliver your baby? It's certainly you have a heart attack. It's all of us. And so when we think about, there is an estimate on the bill that over 300 hospitals will close as a result of this legislation. We already have seen hospitals talking about the impact of these cuts. And not only, are we hearing about closing, but also decisions changing about whether or not they're going to open a wing. These choices hospitals have already been on a razor-thin margin in much of our country.
And Doc, is that just the hospitals? We talk about nursing homes as well.
That's right. I mean, nursing homes are impacted because many of our older patients that are dual eligible, these are individuals that are both getting Medicaid and Medicare, are in our nursing homes. There's provisions in our nursing homes that deal with staffing levels and ensure that there's no real criteria for staffing levels to ensure that our patients in nursing homes get the care that they need. Roland, this is a big issue. Now 60 years, and I know that we're having this conversation on 60 years since this Medicaid and Medicare were passed in the Social Security amendments. We don't need this to be rolled back. I'm a forensic pathologist, and I often say that I see failed policy on my autopsy table. And that's the truth. I mean, you just talked about the death. It is the medical examiner's offices and the morgues that are going to be telling the story about the deaths that happen in this country. And I happen to be a hospital president as well in a safety net hospital, Howard University Hospital, Freedman's Hospital to begin with. And, you know, we are having the conversations. How do we deal with the cuts? What types of outreach are we do to individuals that we know are going to be just purged from the rolls because they have not kept up with their 6 months re-up on their Medicaid, right? So this becomes a penalizing people for not being able to meet a deadline, not necessarily ensuring that people that have care have care. And so we have to develop a whole outreach initiative to ensure that our patients, which are the majority Medicaid patients and Medicare patients, have the necessary reminders, have the necessary technical support to be able to fill out the paperwork so that they don't lose eligibility when they are actually eligible. And so there's a lot of tricks in this bag that we have to keep our eye on. The good news, if there's any good news, that many of these provisions don't hit until 27 and 28. So, you know, several that are hitting now that we have to watch, but there's some that we have some time. And so there's work that can happen now, particularly in the voting booth, to make sure that that these types of changes don't actually take hold.
Questions from my panel. First up, Rebecca.
Hey, Dr. Mitchell, good to see you. Congratulations on becoming the president of the National Medical Association. You mentioned that people have to become healthier. And currently, most medical schools don't require students to take a nutrition course during their didactic years. Should there be a push for nutrition to be included in medical curriculum?
Yeah, absolutely. And I'm glad you brought that out. The National Medical Association, actually, one of my pillars is surrounding food as medicine. Here at Howard University College of Medicine, we have our wellness vice dean, who is a food as medicine expert. Food as medicine and this type of nutritional health is coming in to medicine now. So I think it's critically important to teach nutrition, to teach healthy living. But one of the things that Chiquita will tell you is that we were moving down this road towards value-based care. We were moving down this road towards really incentivizing prevention and screening and making sure that people were getting into care early. And that's really what I'm talking about, not necessarily switching the onus onto the patient, but really incentivizing both the patient and the provider to say, hey, listen, you need to get people in your cluster of patients. You need to make sure that you're checking on whether or not they're checking their cholesterol and their blood pressure, checking their prostate, checking and getting their regular mammograms. So if we're going to find disease, let's find it early and be able to treat it early before it becomes life-threatening and before it becomes extremely, extremely expensive. And so nutrition and food as medicine in the curriculum is important, but making sure that we understand value-based care also should be in the curriculum as well.
Robert.
And for both of you, thank you so much for the work that you do and the information you provide. A few weeks ago, when the big brutal lie, the bill was going through, I found that there was a information gap between the folks who knew and understood what was going on and then everybody else. Even if you looked on CNN the day the bill was being voted on one screen, half of the screen they had the vote, on the other half they had the Diddy trial. What do you think has to happen for us to be able to explain this information to average people so that, one, they can understand what's going on with it, the fact that many of these cuts are backloaded, so they're not going to come in place until after the 2026 election, and they need to make provisions in the meantime for what that will mean for them, but then also how they can fight back against this and politically and understand that this is not the time for apathy, but they are literally cutting healthcare from 15 to 20 million people, and there's not a lot we can do about it unless we get out and vote in the next election.
Well, I'm so glad you raised this, because we all are struggling with the fact that once people knew was in the legislation, they overwhelmingly rejected what was going on in terms of the healthcare provisions, but awareness was really low. I think what we all need to do moving forward is make sure that people are really aware of what is in this bill. And I think one of the challenges is that we had a debate on healthcare during the first Trump administration. It was Affordable Care Act, repeal and replace. People understood very clearly that Republicans wanted to take Medicaid and ACA coverage from you. But this one was really more challenging. There are dozens of provisions, some of which are very detailed and hard to explain. But some of these provisions are going to take place this fall. And I want to make sure that people know that if they start to see what we expect, which are 20% increases in premiums for people who are on Affordable Care Act coverage, which means hundreds of dollars for some people, thousands of dollars that they will pay more this fall. We need to make sure people know that is because of this bill and the decisions that are being made by this administration.
Yeah, and I'll just add to Dr. Brooks LaShore's comments. It's really trusted messengers like we have here on Roland Martin and the panel to really bring these issues to the forefront. It is, we're spending a lot of time on Epstein and a lot of time on really the sensationalized issues when this is happening right now, and this is going to affect lives. And I think that the more conversations that we can have about this, the nuances, really creating a volunteer pool of individuals that are going to help people understanding that part of that work requirement is 80 hours for every month. How do we as community develop and ensure that everyone has documented 80 hours if indeed that work requirement ends up going through, right? And so we can use that volunteer hours to teach the issues surrounding Medicaid and make sure that the individuals don't fall off the rolls that don't have to, and then make sure that people become eligible. There's a lot of education that we need to do. And that's why on the 60th anniversary of Medicaid and Medicare being signed into law, you having time to have this conversation is extremely important, but one time is not going to do it. We need to be constantly having conversations, and the NMA, obviously is standing by to be able to be that trusted messenger for our community.
A final comment.
Just to say you were showing pictures of the presidents, Truman and LBJ, when they were signing the Medicare and Medicaid becoming into law. It really changed our country. And we need to continue to move forward in our trajectory of getting more people covered and making sure they have access to better care. This bill pulls us back, and we need to make changes so that we don't move backwards.
All right, then. We're surely appreciate it. Gita, thanks a lot. Doc, thanks a lot as well. Keep up the fight.
Thank you.
Hello, I'm Isaac Hayes III, founder and CEO of Fanbase. Listen to what I'm about to tell you. The window to invest in Fanbase is closing. We've raised over $10.6 million of our $17 million goal. That means there's room for less than 6,370 people to invest in Fanbase for the average amount. The minimum to invest in Fanbase right now is $399. That makes you an owner in Fanbase today. Go Go to startengine.com/fanbase to invest. Why? Because current social apps have taken advantage of users for far too long, with content suppression, shadow banning, harmful racist content, and no real tools for monetization and equity. Fanbase has over 1.4 million users and counting, allowing anyone to reach all their following and monetize their content from day one. Social media is the new TV, and whoever owns the apps that distribute that content have the opportunity to own potential billion-dollar companies. While big platforms with uncertain futures are failing to serve their users, Fanbase is stepping up to fill the gap. Don't wait until it's too late. Invest now, invest for yourself and your future. Go to startengine.com/fanbase and own the next generation of social media.